All right, greetings and welcome everyone to our Decolonizing Global Health series, the fifth of our series titled Disrupting and Rebuilding Global Healthcare Systems. So I'd like to turn it over to my colleague, Tony Lemieux, for some welcoming remarks.
Well, thank you, Parmi, and thanks everybody for being here. I'm Tony Lemieux, the founding co-director of the Atlanta Global Study Center, and we were really fortunate to be able to partner with our colleagues at Emory and to join forces to add this great event as a starter for our kind of kicking off our Atlanta Global Studies Symposium. So it's over the course of this week that we will have a whole host of sessions and panels to talk about a wide range of topics sort of centered around the UN Sustainable Development Goals and focusing on issues related to resilience. And just by quick introduction, the Atlanta Global Studies Center is a collaboration between Georgia State and Georgia Tech, and we have partners across the metro area at Emory and Spelman, Agnes Scott and Georgia and so on, where we're building international awareness, global competence, supporting advanced language learning, and really taking on the sort of big globally pressing issues and themes. So I'm really delighted to be part of this and to be able to join forces. And so back to you, Parmi, and thanks again.
Well, great. Thank you, Tony. And so on behalf of Emory and Emory Global Health Institute, I'd also like to welcome you all. My name is Parmi Suchdev, and I'm the Associate Director of Emory Global Health Institute and a professor here at Emory. And so just as a means of introduction, we've had this 5-part series titled Decolonizing Global Health, really with the aim to start a discussion with our broader global health community, faculty, students, practitioners, really across the US and across the globe. And we've done this through 5 sessions, starting last November, and really the goal is to acknowledge really some of the conception of fabricated class, caste, religious, and ethnic superiority, and to really, most importantly, work collectively as a group to dismantle these hierarchies and rebalance global health. So that's our cause. It's not an easy call, but one we hope to address through these series. And for those of you who missed some of our prior sessions, they're all available online on our Emory Global Health Institute website, and this session will be recorded as well. And just some brief logistics. We ask everyone to please mute yourself, and if you have questions, you can put them in the chat. And essentially, we'll be going through a series of short presentations by our panelists, and then we will have time for actually a breakout session. We're gonna break you all out into 4 breakout rooms randomly to kind of have some more continued discussion, and we'll come back finally as a group. And so with that, I'd like to introduce our moderator for the session, who will then give us a brief overview of our goals for this session and also introduce our panelists. So our moderator is Dr. Jenny Ward Robinson, who's a Senior Advisor to the Dean and Director of Operations and Outreach at the College of Arts and Sciences at Georgia State University. And she has over 20 years of global health leadership experience. Notably was former CEO of the PAHO Foundation and has done some other tremendous work across many regions in global health. And most importantly, she's provocative and is gonna really provoke our panelists to address some of these really challenging issues about how do we disrupt and rebuild global health systems. So with that, I'll turn it over to Jenny.
Thank you very much, Parmi, and thank you to Tony for allowing me the opportunity to be here on the behalf of the Center for Studies on Africa and its Diaspora at Georgia State. We are really thrilled and we're really excited to be part of this critical series. And we hope that you, the audience today, will find our discussion stimulating and challenging as we tackle the issue of decolonizing global health, deconstructing and rebuilding. Of course, the topic is timely in light of the fundamental questions that are being considered globally. The issues of justice, equity, and solidarity must all be infused in our pedagogy, in our practice, and in policies globally. And at the heart of global health, these issues must reside and become the driver. And in fact, I'd like to set the stage by having you consider a statement made by St. Augustine back in 1664. St. Augustine, is from North Africa. charity is not a substitute for justice withheld. So as we set the stage, what I'd like to bring to your attention is just a brief overview of the speakers, and then I'll give a little bit about the topic that I hope will be as provoking as Parmi said, and I believe you will realize this will be lived up to by our speakers. First, you will hear from Dr. Eugene Richardson, who is a professor of global health and social medicine and the co-chair on the Lancet Commission on Reparations and Redistributive Justice. And I know that everyone knows that this is a topic that is not only resident in dialogues and in communities in the US, but internationally. He will be followed by Dr. Osama Tunus, a Hubert Humphrey Fellow, who will focus on humanitarianism with respect to occupation, militarization, and the voices that are often silent in the system of saviors and victims, as I call it, when global health moves to countries where culture collides with the intent and intentions and practices of those who bring global health. How do we really save lives and improve quality of outcomes in that setting? And finally, we will be directed to a conversation by Kelly Callahan, who is the director of the Trachoma Control Center at the Carter Center. Dr. Callahan focuses her work on a grassroots approach to global health, and at the heart of what she does is compassion. I think that you will find this very exciting. So let me sort of create a space for this, because when I think of global health, I think of reducing health disparities and addressing equities. Systems of inequality persist. And when I think of colonialization, I'm guided by the work of Anibal Quijano, the Peruvian sociologist, whose work focused on the dynamic, the matrix of power and power relations that continually manifest transnationally, and often fail to recognize the political, social, education, and personal independence of the settings in which public health is delivered. When I think of decolonialization, I think of the UN model, where we have to recognize knowledge shifts, power shifts, and that operating frameworks that guide private global health practice must transform from a donor-centric funding to co-created models of response through localized lens. If we adhere and are guided by this and what you will hear from our speakers today, then global health will become contextually based, and the structures that are built will reposition solutions and foster inclusive rather than intrusive outcomes. So I would argue that in pedagogy, we must consider partnerships in low to middle income countries with those previously recognized as colonizers. We must understand and look at the assumptions that are often driven by those who fund. We must recognize that local contributions of the context in which global health is delivered has expertise and infrastructure that is necessary to be inserted as assets in addressing global health. And if we do that, we will then be able to deconstruct global health and reconstruct a platform of service that really serves the community intended when we go abroad and when we engage with those where we seek to deliver global health. So with that stage, I'd like to invite our first speaker to take the mic, Dr. Eugene Richardson. Please welcome him to the mic.
Thanks so much, Dr. Ward Robinson. It's an honor to join this panel of champions of justice, and I'm excited about the discussions to follow. I'm going to present briefly on mainly from a book I just published called Epidemic Illusions on the Coloniality of Global Public Health. And it builds exactly on some of the foundations you talked about, notably Aníbal Quijano and theories of coloniality, and how the matrix of power that was developed 400 years ago still permeates knowledge production, economic relations, etc. So next slide, please. So here's the cover of the book, and the idea is that with this image is that it's a play on Plato's cave, which essentially said that there was a single cave and there were these people chained, and all they could see were the shadows of these images, and that's all they knew. And then one of their lot, the social scientist or the philosopher, escapes, goes up into the sun, sees what things are really like, and comes back and kind of tells them, this is the way things really are. And that sort of universal approach to knowledge production, I think, is at the root of coloniality. Were we to see the metaphor, the allegory, as a warren instead, where there are lots of boroughs, there are lots of ways of seeing the world, lots of ways of interpreting phenomena, lots of ways of curating your facts as far as social phenomena are concerned. So I'm not talking about, disputing that masks prevent COVID transmission or tobacco causes cancer. But when we're talking about human behavior and social phenomena, there are ways to curate these facts and interpret them that are, your pre-held ideologies cannot be divorced from. And so there are ways of curating facts that support neoliberal ideologies, and there are ways of doing it that support social justice. And I'll get into some examples of it. But this is what the warren is meant to show, that there are different ways of interpreting the world that vie for the forefront of our consciousness. And they should all have a seat at the table, because in a pragmatist notion of truth, we come to agree upon, truth is what we come to agree upon. But most of the time, these other views don't have a seat at the table. And usually it's because they disrupt elite interests. Next slide, please. So to start, my positionality. So my aim is not, as a white man, professor at Harvard, to, talk about the experience of oppression. Rather, it is, since I've worked in the world of the WHO and the World Bank and NGOs and the CDC and Harvard University and things like that, I've been in a place to see how harmers do their harm. And so mainly the book is a report on, is an observations of how harmers do their harm, mostly in the realm of global health. Next slide, please. So here's the definition of coloniality that Dr. Ward Robinson brought up from Aníbal Quijano. It can be described as the matrix of power relations that persistently manifest despite a former colony's achievement of nationhood. It attempts to capture the racial, political, economic, social, epistemological, linguistic, gendered hierarchical orders imposed by European colonialism that transcended independence and continue to oppress in accordance with the needs of capital accumulation. And again, it's not an all-encompassing word. People will argue that maybe racial capitalism is something better. Kwame Nkrumah talked about neo-colonialism because, for example, my colleagues that are descendants of people enslaved in the US would say we were not, ancestors were not colonized, they were enslaved. Or people in India would say we have this caste system. It's not really a colonization. I kind of look at it more as a metaphor phenomenologically of people's life worlds are colonized, whether it's through a caste system or whether it's through patriarchy. I've worked with women in the Democratic Republic of Congo that would say things like the men are colonizing us. And so it's more of the relationship that we're getting at, and then the actual description of a metropole and periphery. Next slide, please. Another definition from Ramon Grosfoguel from Berkeley says that the heterogeneous and multiple global structures put in place over 450 years did not evaporate with independence. We continue to live under the same colonial matrix of power. So we've moved from global colonialism to the current period of global coloniality. Next slide, please. And then Sabelo Ndlovu has to say, despite the celebration of decolonization as a milestone in African history, which is where I do most of my work, Africa has not managed to free itself from epistemological colonization, inscribed on the continent and its people by mission and secular schools, schools of medicine, schools of public health, religious denominations, and other Western institutions that carried Western cultural imperialism. That's essentially what the book is about, how what we call public health science isn't necessarily this objectively neutral foray into gathering capital T truth, but rather something that carries Western cultural imperialism. And so my plea is for people, the way to disrupt, I think, is for people working in this realm to realize that it's not always that they're after these, truths to share with people. More often, they should be after how they're used as instruments of power. And I'll show you an example of how I think IHME is used as an instrument of power in a few slides. Next slide, please. Another thing to keep in the back of the mind is, these moral debates. Are the descendants of colonialists in the global North morally related to people in the global South as saviors? I think that is the predominant way of thinking about things and is why we have this aid development model. But if you really see the moral relation as supporters of and beneficiaries from a global institution and order that systematizes this oppression, i.e. coloniality, then the interventions turn from this aid development model to reparations and redistributive justice. And I'll talk a little bit about an example of that. Next slide, please. So what I'm most interested in is epistemological colonization, or how people's perceptions are colonized. And I go through a lot of examples in the book how I think how public health science does this, how it tells people, how it imposes upon them a way of understanding health phenomena that really supports neoliberal ideologies and elite interests, and that their views, which are often more relational and or a historical consciousness of depredation, actually are pushed aside. Next slide, please. I also use this term bourgeois empiricism to describe models of disease causation that obscure socio-historical forces. They are political acts in themselves because they give support to social structures that hide behind scientific objectivity to perpetuate dependency, exploitation, racism, elitism, and colonialism. Next slide, please. Also use this term symbolic violence. It's all kind of along the same lines. This capacity to impose the means for interpreting social phenomena by representing the world in economic and political world in disguise, taken for granted forms. And here's an example of a paper using that foundation about the Ebola survivors in Sierra Leone. Next slide, please. I also use détournement, which is this kind of French method from 50 years ago about turning advertisements and posters and things like that on their head. So, here you have the Ebola poster that you saw where I was working as a clinical lead for Partners in Health in Sierra Leone during the Ebola outbreak. And this to me is, basically gives people advice, but also sort of concentrates the idea that Ebola is the cause of these people suffering and that they just need to go to the health center to get better. Really, if you see Ebola as just as a marker of all these socio-historical determinants, then here's a poster that might, explain things better. So we have epistemic violence, structural adjustment, the Holocaust of slavery, barbaric colonialism, purposeful underdevelopment, illicit financial flows that lead to the underdeveloped health centers that caused the outbreak to spread in the first place. We showed in a paper that had these illicit financial flows been prevented in Sierra Leone, there would have been enough resources to build a health infrastructure that stopped Ebola in its tracks. And I'd like to point out this slide in particular to show that development is essentially a farce. In 2017, $160 billion came into the continent in the form of aid loans and remittances. $200 billion came out in illicit financial flows, just illegal money theft, tax evasion, trade misinvoicing, resource theft. So the continent is a net creditor per year of $40 billion to the global North, making this idea of development really a farce. And so Kwame Nkrumah already taught us this back in the 1960s when he said, aid is just a revolving door for sort of hiding, giving a little with one hand to disguise what's coming out with the right. Next slide, please. So quickly, just a critique of mathematical models and how they commit symbolic violence. I think of them as merely fables dressed in formal language, because really what the job of a model to do is to forecast our future, so to enlist our social imaginary in envisioning a better future. And for the most part, I think they don't help with that. They perpetuate status quo relations of inequality by not, by kind of disguising any, radical, or hiding any, preventing any radical intervention from coming to the fore. Next slide, please. So, I talk in the book about, there's critiques of causal inference, big data, regression modeling, and epidemic modeling. If you're interested in a good critique of causal inference, this is one of my favorite papers. I know Randy Packard had been joining some of these sessions. If he's on today, one of my favorite books is White Plague, Black Labor, along with, Black Skin, White Mass by Fanon, and then the Neocolonialism, Last Stage of Imperialism by Nkrumah that I had just mentioned. Next slide, please. So the quick critique of the Institute for Health Metrics and Evaluation and how they commit symbolic violence and perpetuate racist status quo. Here's a good article in The Nation. Are Bill Gates' billions distorting public health data? I think yes. Next slide, please. Their forecasts from last spring were, wrong 70% of the time. So to begin with, they're wrong. But then they were used by Trump to say that he was doing a good job. So they were easily co-opted for ideological purposes. Next slide, please. But as I mentioned earlier, they endorse a future where, COVID disparities continue to exist. So they might say wear masks and social distance. And so what we get from 1 million deaths to 300,000 deaths. But in both of those, there's still 3 times the number of Black people dying. And so, they are endorsing this future where, again, institutionalized racism is rampant, hyper-incarceration is ongoing, UHC is denied, and these disparities continue to exist. So by Ibram Kendi's definition of racism, which is a policy or analysis that either worsens inequity or continues status quo, then they are racist because they continue status quo disparities. In short, they actively delimit through their exaggerated precision and acceptance of government interventions, the public's ability to imagine social alternatives. Next slide, please. To imagine social alternatives, we formed this Lancet Commission on Reparations and Redistributive Justice. Next slide, please. One of our first papers came out last month, Reparations for American Descendants of Persons Enslaved in the US, the potential impact on SARS-CoV-2 transmission. We basically showed that reparations paid to this group maybe 10 years ago would have reduced COVID transmission across races in the US, not just in the highest risk group, 30 to 60%. Next slide, please. And, it got coverage in CNN, and we got lots of hate mail, which we continue to get. And this is maybe something we can talk about in the discussion. Next slide, please. But overall, my project is to trace human rights failings to the impoverished discursive infrastructure of objectivist epidemiology and transforming global health by transforming its representations and working to transcend the aid development model to a more reparative justice model. Next slide. Thanks so much, and looking forward to the rest of the discussion.
And now we will hear from Dr. Tanous.
Thank you, Jenny and Parmi and everyone for the invitation. It's really an honor. Thank you, Eugene, for the excellent talk. I will talk about humanitarian medicine, my experience with it, and the origins and decolonization of humanitarian medicine. Next slide, please. So I will just try to touch on the origins of how humanitarianism started and why, how it was transformed over time. I will take Gaza as a case study. It's a place where I have worked and volunteered and been a part of a humanitarian mission, and then trying to discuss how we can decolonize humanitarianism. Next slide, please. Okay, so I think it's very important to focus on this very specific moment in time in the end of the 19th century, that until that moment, until the Boer War in South Africa, colonial powers could simply engage in mass slaughter with the enemy population. You know, they were teaching them lessons. These populations were Black or brown or Muslims or Indian, and you can easily engage with simply a manslaughter of mass shooting, killing, deportation, anything, for any reason you would like, right? For example, the war in Sudan was intended to secure the Nile, so the British troops, you know, just entered to face the Mahdi revolt, the Mahdi uprising in Sudan, and it was, as most colonial wars, a very clear manslaughter. And just 1 year later, there was a crisis because suddenly the colonial powers were dealing with an enemy that was not Black, that was white, and that was European. And these are the Dutch farmers in South Africa, the Boers, as they are called. So when England, when the British Empire wanted to secure South Africa to secure its grip over South Africa, it suddenly encountered for the first time an enemy that is white, right? And you could not engage with the same tactics that you could do before of mass shooting and mass killing, because these are humans, right? They are not particularly maybe an enemy population, right? They are graded differently. And then there was a lot of support for the Boers in Europe itself. So the Red Cross of Germany, Denmark, and other countries started sending humanitarian medicine to these population and talking about concentration of women and children and so on. And this made a very clear change and marked the origin of how we can understand the humanitarianism in wars as it is being discussed. Next slide, please. So what we can really often think of as a very naive and instinctive feeling of humanitarianism, wanting to serve the other, is simply a product of wars. And instead of being an antithesis to war, how to stop wars from happening, it became a way to allow powers and colonial powers and then imperial powers to fight wars with compassion, legally and respectfully, rather whatever that means, you know. So countries that claim to be democratic or to uphold to some standard of human rights, who engage in asymmetrical warfare, you know, with not as often non-state actors, they would talk about humanitarianism in war. And wars have significantly transformed over time. Next slide, please. So if we were thinking of the World War I and other wars waged in Europe between two armies in a battlefield, and somebody trying to claim neutrality, wanting to take care of the wounded people of that war, wars have significantly changed. They are not frontal anymore, right? They take much more time. We don't know when they end, when does the war in Iraq ends or Afghanistan. And humanitarianism, not always, but by someone neutral, by the same power that is waging the war, is often integrated in the structure of waging wars. Next slide, please. So the simple, arguments for humanitarianism, that it is a moral duty, that somebody is neutral, we as neutral doctors or practitioners or citizens of the world, want to alleviate the suffering of other people. We want to help in their development and to help in their aid, instead of really thinking and understanding what is the source of the suffering and how it has been historically built, and how we can prevent wars from happening in the future. How we can truly discuss the budget, the military budgets of European countries or the USA, and where they are being sent and spent. It ends up creating a class of saviors that tries to help a class of victims, based on their notion of innocence, that these are innocent people who do not deserve this. They are simply, pure and kind of did not do something wrong. right? Instead of really sabotaging the whole concept. It very much deploys the concept of innocent. It doesn't, instead of really tackling what is the core issue, in order to alleviate the kind of fear and usual indifference to the suffering of other people. If we can really think of the global map, how it is happening, mostly there is simply indifference, right, to the suffering, to the hunger, to the wars overseas. But then it's of a humanitarianism, and humanitarian medicine often deploys images of children, of women and children, of cancer patients to motivate innocence as a motivating rather than the entire structure of the production of the building stone of diseases, of wars, of suffering. Next slide, please. Instead of really, if in the previous we would think of humanitarianism as something that was parallel to the power structure, parallel to the wars, to the imperial wars, now it becomes simply integrated within the spending, within the budgets of the U.S. empire, of wars. You know, we spend this amount of money on military and this amount on budget, and then this it becomes integrated in the larger scheme of how wars are being fought, instead of how and wars eventually, you know, will lead to the countries being poor, to the destruction of healthcare system, to the destruction of hospitals and the complete infrastructures. But humanitarianism becomes a part of the game. It is not radical. It is not an antithesis. It doesn't try to change it. And it, if we are talking about decolonization, which is disrupting power structure, it simply does not do that. So it becomes an integral part of liberal warfare, pacification, counter-insurgency. Next slide, please. Okay, so I will just touch a little bit on Gaza, on a place that, and in Palestine in general. Palestinians are the largest receivers of humanitarian aid per capita. So this is the map of the transition of Palestine. Palestine has been subjected to settler colonialism, similar to the USA, Canada, and other parts of the world, where the definition of what is Israel, what is Palestine, where does it start, where do the settlements start and begin, has been a product of ongoing reshaping of colonial frontiers. And these colonial frontiers have created the Gaza Strip that we see here. It is not a natural geographical unit. It has been created by frontier expansion and has become simply a dumping ground for refugees from historical, from other places in Palestine, and then been sieged, attacked several times. Next slide, please. And this is Gaza, as a lot of you see it on the news. After being created and colonized, it's often bombed and sieged. And then next slide, please. But then when there is no war, it simply is one of the biggest prisons on the planet, right? So simply an open air prison where people cannot leave, cannot go in, cannot go out. But we as humanitarian missions can go in to try to help. Next slide, please. So I'm a part of the Physicians for Human Rights group and participated in humanitarian missions to Gaza. And it became incredibly frustrating because and I wrote this article in the Middle East Research and Information Project about the dilemmas of practicing humanitarianism. And, you know, humanitarianism came with the logic of helping people at times of crisis. There's a war, the war will end. So now until the war ends, we help patients who have wound injuries and so on. But when wars have taken such a long time, if we look at the wars in Palestine, in Iraq, in Syria, and in other places of the world, where war have become much more chronic and takes years and decades, and also diseases, the diseases of people at war areas, when there are no bombing and shooting, people die from diabetes and heart diseases and a lot of the the usual kind of cardiovascular and cancer diseases, that simply a parachute mission going in, going out will do nothing. So I was repetitively frustrated by not being able to do anything, but just, counting that we've seen so many number of patients, we've done this amount of surgeries, but then when there is no healthcare infrastructure that is able to support these patients, our work was simply useless, and these hospitals were being completely bombed or de-developed or defunded. So next slide, please. And in that sense, here the aid as a concept, especially US aid, that fuels the weapon industry that really bombs Gaza, that gives a diplomatic support to Israel in its siege on Gaza and bombing of Gaza, ends up at the end of the day trying to build roads in Gaza and in the West Bank, and this is the usual response that you would see from Palestinians. Next slide, please. Just want to summarize that there is no such thing as humanitarian wars. The role of humanitarianism in medicine should be trying to prevent wars, trying to have wars to expose what are the alibis for having these wars, and not to continue the ongoing process with some kind of cosmetic changes. And this would be a way to be more radical and to decolonize it. And if Palestine is a place for direct war and bombing, different parts of the global South suffer from different maybe warfare techniques that are not direct wars, but de-development, exploitation, and so on. And thank you very much.
Thank you, Tanus. You have certainly given us a lot to think about, and I can't wait to engage with you when the question and answer opportunity emerges. Now we will hear from Dr. Callahan, and again, looking forward to this opportunity to engage. Dr. Callahan?
Thank you very much, Dr. Ward Robinson and Dr. Suchez and the organizers for inviting me to speak today. I really appreciate the opportunity. I'm going to take a slightly different tact and talk about a little bit more of a focus on rebuilding and using some of my experiences over the past 25 years as platforms for rebuilding. So next slide, please. I would contend that disruption is underway. I think that's perhaps my positive, optimistic side of me. But if we look at how global health has developed over time, from the 15th century to the early 20th century, colonialism, this was the conquerors, the self-interest, the self-protective interest of these conquerors. And then moving into tropical medicine, it was very much paternalistic, infectious disease controlled, us versus them. And then in the 1960s, international health moving more into the foray. And now we're moving more into global health as a definition, which seemingly is more maternalistic, based upon partnerships and systems. The mission is more aligned and it's more holistic. Next slide, please. So all of these conversations that we're having, and this one focused on disruption, and what does that mean? It's underway, and we are having these conversations. It's clear that there are tenets that continue to come up and are pushing this conversation. However, compassion, love, and shared humanity are not considered core values within the context of this conversation. Rather, as was noted by the two previous speakers, scientific foundations and endeavors, the economy, market forces, politics, military, civil defense, us versus them, are still considered core values. And therefore, we continue to have a lack of vision. Next slide, please. And this lack of vision could stymie us in terms of rebuilding, but my thoughts on this are that if we look at rebuilding with a different lens, a lens that is foundational, that lays the groundwork, co-created models of response. I love what Dr. Ward Robinson said as we opened, must be foundational, must be co-created, and they must be models that respond to the context of the countries. It must be inclusive of all global health perspectives, from the health worker to the health facility, the physical infrastructure, the community, the district, the national, and the global, in terms of the Sustainable Development Goals and other aspects of all of the member states and what they have bought into in terms of a global health perspective. And it must be focused on equity and justice, and it must be partnership and systems focused. And in order to do that, next slide, please, I contend that we must include compassion, and compassion must be the foundational element of what we're looking at in terms of rebuilding. And you can read the definition of compassion, and it is an important definition: consciousness. We are moving from colonialism, we are disrupting colonialism, and now we move into a state of consciousness. And in that consciousness, in that rebuilding, we have to bring in compassion as elemental to this. Next slide, please. And the compassion equation, it's required at every level that I just described. And this equation can be defined as awareness, the cognitive awareness of suffering, empathy, the emotional resonance with the suffering, and then action, a commitment to alleviate suffering. Next slide, please. So in this awareness, building systems with compassion, I'm using two examples from my experience. I've been with the Carter Center for 23 years, and prior to that, I was a United States Peace Corps volunteer. And I chose these organizations for multiple reasons, but the reason that I chose the Carter Center is that it has a fundamental commitment to human rights, and it emphasizes actions and results. Also, understanding that people can improve their lives when provided the necessary skills, knowledge, and access to resource. Delivery is through government infrastructures, which is incredibly important, and it's not for them, it's with them and through them. And our delivery of health is at the community level. We focused on eradication, elimination, and control of infectious diseases as a core component and a core value of our system at the Carter Center. Let's remove those things that are causing people the most suffering so they can continue to improve their lives, provided they have the skills, knowledge, and access to resources. Next slide, please. And also the United States Peace Corps. It is focused on three tenets: to focus on the people's needs for training. What are the people's needs? And then to better understand Americans. This is a promotion of peace. How do we understand each other? And then how do we take that understanding back to America to break down these barriers that we have with race, with other, this us versus them? How do we continue to break that down? Again, implementation is through the government infrastructure, delivery of health services, and all services is at the community level. And there are shared core values, and it's based on understanding with the focus towards peace, interconnectedness, and shared learning. Next slide, please. And as far as the empathy portion of this, it's interesting that Eugene that quoted has the foreword to his book from Paul Farmer. I believe that we need to focus on compassion as the core value, not because it's simply my belief. There is an enormous body of evidence that compassion is necessary and can improve people's lives, can improve quality of services. And in September of 2010, 10 of the world's leading health experts came together at the Carter Center to discuss the role of compassion in global health. President Carter hosted this meeting, and the participants included Bill Faggy, George Allen, and many others. Paul Farmer talked about compassion as a participant at this meeting, and talked about it is not just acknowledging the suffering of others, but it is about saying, well, how much of this suffering is premature or even unnecessary, and what might we do to collectively lessen it? President Carter said this exciting conference is unique in my experience. And I think it's the opportunity to share some of one's own experience with others to bring it out into open and publicly connect the words compassion, love to what we're doing. It's very important. Next slide, please. And Bill Faggy said of this conference, in epidemiology, you are oftentimes dealing with graphs or tables or numbers. So it's important to be grounded and force us to see each other. Compassion changes as we see each other in each other's eyes. Bill Faggy, when he was the director of CDC back in 1984, was really the first person in a public role to talk about compassion and the need for greater compassion in all that we do. Next slide, please. As part of the science of compassion, these shared core values of compassion and love and interconnectedness, they change how global health works. They improve service quality of care, and customer service levels. They generate higher levels of innovation within organizations, and it allows for more effective cooperation for people across multiple domains of expertise. When we see each other in each other's eyes, we tend to be more cooperative. We improve service quality. We generate higher levels of innovation. This is phenomenal simply by the tenets of compassion, love, and interconnectedness. Next slide, please. So I would argue in a loving way that as we moved from these colonized health systems to a global healthcare system, we need systems change, and therefore we must integrate love, compassion, and interconnectedness in all we do. We have to interrogate global health core assumptions and values. We have to really question why the market forces, why the force of economy, why the political forces are at play. And in that, question our core curriculums as educators. We have to advocate for transformation of our curriculums. We have to learn from each other and the past and develop partnerships based on equity and compassion. Next slide, please. So I would contend that as we talk about the actions to rebuild global health systems, we need a compassion revolution. Revolution equals rebuilding, equals a re-education, which means developing a compassionate curriculum at all levels, master's, doctoral, from the epidemiologists to the statisticians to, Eugene wouldn't like me saying it, but the modelers. Across every strata of global health, we must develop a compassion curriculum. And I challenge that we are the ones to do that. And this conversation must come from all of the different elements that form our global health education system. Next slide, please. So in that, these thoughts are not my own. Imitation is the greatest form of flattery, of course. And the focus area for compassion and ethics and the Task Force for Global Health based in Atlanta, Global Health Compassion Rounds, the WHO Global Learning Laboratory for Quality Universal Healthcare, and the Center for Compassionate Leadership have been building this conversation of compassion over time, and I've been fortunate to be part of this conversation. I will also end with this year, the American Society of Tropical Medicine and Hygiene will be having a greater focus on compassion and what that means in terms of our systems, our global health systems. Where are they? Are we a force of compassion? And how can we use compassion to improve our inclusiveness rather than our oppressiveness? How can we co-create models of response to meet people's needs where they are and ensure that we're not doing so from some white savior perspective? And with that, I again believe that compassion and having a curriculum of compassion so that we are doing things, we are working, we are building global health systems together on a platform of partnership rather than oppression. And with that, I'll say thank you. I appreciate the opportunity to talk about compassion. And as you can tell, I'm compassionate and passionate about it. And I look forward to the discussion. Thank you.
Thank you, Dr. Callahan. This is absolutely exciting. All three of you set a stage for our dialogue that will happen. And I will turn this over to Parmi in a minute, but I wanted to say that what is resounding across the three conversations is the need to fundamentally rethink global health from pedagogy, practice, policy, and funding, and do it with an underpinning of compassion. This is absolutely exciting, and the points are all excellent. Thank you. And I will turn it over to Parmi, who will give us our instructions for the breakout rooms. Parmi, please take the mic.
Absolutely. Well, yeah, again, thank you guys. And I know like me, all of you have probably a lot of burning questions. So we're going to try something novel. What we're going to do is everyone who's in this room is going to be randomly assigned to one of 4 breakout rooms with our 3 panelists and Dr. Ward Robinson. And it'll be your chance to engage with them in a bit of a small, more intimate setting, ask questions. But then really, we want each of these 4 rooms to really ask the question that Jenny just said, like how can we transform the practice of global health, and what are some concrete things you think we can do? And then you'll have a facilitator in your room who will take some notes, and then we'll come back together as a larger group and continue the discussion. And so we'll do this for about 15 to 20 minutes. So just hang tight, and Britton will send us to our rooms. So thanks everyone for participating in that. That was a bit of an experiment, but hopefully, I mean, just looking at your guys' notes, which I can see, you all had some rich discussion. So I think rather than going through each group by group, I'll turn it over now to to Jenny and the moderators and the panelists. If anyone, so you guys can kind of take some of the themes that came up. And maybe highlight some questions that or discussions that came that you think the larger group would benefit from. So over to you guys.
So I'll start by sharing a couple of key takeaways from the breakout group I chaired, and then I'll ask the panelists to comment on what came out of this. One was the idea of how do you address and how do you shift pedagogical structures in order to insert the idea, the construct of compassion. And I actually expanded that to think of humanities within the work of global health. And one of our participants offered that there should be, in order to really construct an inclusive relationship, that we should perhaps have a requirement as part of the core of public health that you cannot move past to graduate unless this human quality context is taught in the classwork, so that you bring that to your engagement. And I'd like to first begin with Kelly, since you offered this as part of disrupting the system of education. I'd like you to comment on that. What are your thoughts about that as one idea for decolonializing global health?
Thank you, Dr. Ward Robinson. I actually got cut off in our group because I was at a point very passionate about basically that exact element. Ethics and compassion, those 2 elements need to be part of a core curriculum for all public health practitioners. I can't stress my belief and theory in that enough. And we have to express core competencies towards compassion. understanding of interconnectedness. If COVID-19 has not showed us how interconnected we are, I don't know what it's going to take to show us how interconnected we all are. And so would offer that one thing that I was speaking about in the breakout session is most curriculums across all countries, and let's just be pretty clear about that. Most curriculums are based upon a colonialized curriculum. We're still teaching what we believe was the right thing to teach from years ago. We've had a paradigm shift, and we need to continue that momentum, develop core competencies towards curriculums that are based in compassion and equity, and in that are interconnectedness and ethics. And I would wholeheartedly agree with that. I think it's time to start doing it. We're past time, and it's time to embrace that. We have an opportunity to reimagine what this world can be like based upon what has happened this past year, and the conversations we're having and the questions we're asking each other, and being provocative and holding each other accountable. The cat has out of the box, it's out of the bag. We have been colonizing the world. I say we collectively, in terms of what we have allowed to continue, and it's time to stop. So if not now, when? And I would suggest that we have universities in Atlanta that have deep reach across the world. We have Harvard here, we have University of Michigan. We can develop curriculums with core competencies towards compassion and ethics, and it's time to do it. Thanks.
So I'd like to actually present that same question to Dr. Richardson, but I'm going to push it in a little shift, and to ask you to think about, is this what medical humanities look like? The idea of having the voice of your audience, your recipient, the patient. This is being discussed within the medical community to enrich the quality of patient-physician interaction. Is it time for this to be inserted in global health? And if that is the case, then based on your work, particularly around Ebola, how might this practice be, would have been enriched? And then how do we bring this into the classroom? And finally, I'm going to ask Dr. Tanous, how do we then take this to policy to guide what we think of as humanitarian response? Dr. Richardson.
Yeah, thanks so much. So I'll just use the example of the class in our medical school that I was part of the tutors for, the Essentials of Medicine, where we had the social medicine and ethics part of it. And I've actually left it after a few years because, one, it still was based on this like bioethics model of the bounded individual with perfect agency and information, and like nothing relational taught about it. And so to me, it was a clear example of how, yes, our version of American bioethics is essentially just what I've talked about earlier, a transfer mechanism, an apparatus, a dispositif, of certain ideologies, and usually more ideologies that support, don't ever question status quo relations of inequality. And so, I think the medical humanities has tried to do this, the good job of, bringing, we had this in my med school, like, let's read books, let's have a book club and all this stuff, and it'll make us, more compassionate, yada, yada, yada. I don't think it's enough. And I don't think it actually does the job. And the reason I say that is because you could look at, say, people who have been trained in the British system, where they go straight from high school to medical school, and they're like, qualified doctors younger than us, because in the US, we actually, we do an undergrad degree. And so many people do these philosophy and liberal degrees, and you don't notice a difference between the like compassion or relationality of a British system doctor or a US doctor. So I think that shows that's still built into our programming, how, like, you know, our mind, how we're, you know, how we're set up to interact in the world, are these ways of continuing to support the status quo. And so that's why I wrote the book in a very experimental form, to like try and get out of this, sort of farce that like we're actually doing good through development, like I explained with that slide, or we're actually making more compassionate people by having them read a few novels while they're in med school. So I think the transformation has to come, population-wide, as far as our consciousness is concerned. And maybe it can start with, you know, practitioners like us really transforming how we represent social phenomena and health phenomena in global health. I really think if the people who are entrusted to, understanding health phenomena and curing it, really transform to these, like, racial justice interventions and radical ways of interpreting it, it will trickle down to the rest. But right now, we're mainly just an apparatus of continuing these status quo ways of seeing the world. Thanks.
Thank you for that. And Dr. Tannous, if we could insert the story of the context of the community, of the country with compassion, how then should we think about humanitarianism, knowing that it is driven often by donor funding, whether that donor comes from a country, or from a community, or from a person offering this gift? What changes would you like to see occur then in humanitarian response if we do consider incorporating these factors that recognize what we're talking about?
Thank you very much, Jenny. So as I see it, and a lot of other folks, the end point of humanitarian medicine should be simply to stop existing, right? In the larger outcome, because if historically it has been imagined as there is a temporary crisis, right? There is a war that has a beginning and an end. There is a natural crisis or something that has a beginning and an end. And the humanitarian response is a short and limited response that should end, right? But instead of that, now the whole, first of all, colonial entanglement, the whole, and post-colonial and neo-colonial ways of disposition and taking on resources and natural resources and the sovereignty and so on simply goes on. And so it's not acute, it's chronic, but also wars, right? If we can think in my region, specifically the Palestinian, the Iraqi, the Syrians, people who've been refugees for 70 years, right? And simply humanitarian response does not meet any of the demands or needs or so on. And Israel-Palestine does provide us with a kind of a laboratory, because you have colonial relations and settler colonial relations and captive markets and racial capitalism and all of that in one single geographical unit. It's not overseas. It's not that. And you will see a lot of writings of Israeli doctors and hospitals writing about, treating Palestinian cancer patients and so on, as a way of trying to whitewash a system of oppression and so on. But then when you actually try to trigger that system and say, but why are they occupied, and why they can't return to their homes, and why do they need this humanitarian service instead of of really being able to control, to have sovereignty, basically to control their own land and to control their own resources, and instead of having checkpoints and no ports and airports and being completely dependent, then you are silenced, right? And like some friends in the Lancet have written last year a really nice paper about COVID in Gaza. And when people were talking about the whole if prisons would be such a hotspot for and open the prisons, and Gaza is an open air prison, so the end point should be let people return to their homes, right? Instead of being stuck in refugee camps. That paper survived 3 days in the Lancet, and then it was redrawn, right? But so there's so many ways of silencing when you really try to question the core, what Paul Farmer calls the building stones of oppression. Right. And here I feel a bit uncomfortable with compassion, because as I said, historically, it has been integrated within the war enterprise in order to differentiate between liberal and illiberal countries. So, if Syria, Bashar al-Assad can go on, or like in Spain during the civil war, Franco can go on with like manslaughter, completely bombing people, the US and Israel, trying to claim modernity and some kind of moral values, will wage war with humanitarianism, right? With kind of, we'll say, compassion. We'll corner these people here or do whatever, but with the same amount of casualties and killing and destruction and so on. And it goes on to have two parallel hands, right? So you have the budget to the military, you have budget to the Peace Corps. These are not antagonists to each other. They continue each other in a way and complement each other, and let these people feel good and these people feel good, and yeah, that's it, right? So I would very much advocate for more really questioning the building stones of oppression, the building stone of occupation, of colonialism, of settler and neo-colonialism, of dominant market values, and how they can help us move forward and radically imagine a future where these power relations do not exist.
So if following on what you've said and what Kelly and Jean has said, if we are agents of change and we're to be compassionate and to be concerned and engage our community, our academic models are built on funding, research, and publication. So if this is the system in which global health is developed, and global health practitioners are developed, how do we, and the idea of the power dynamic is very intrinsic in that model. How do we then think of breaking this colonial approach and perspective, knowing that the donor, power, and institutional structures are at the base of global health? How can we then consider and engage this? And Kelly, I'll start with you.
Well, I think everyone knows what I'm going to say. We need a compassionate revolution. We need to build those blocks differently. And Dr. Tannous made such excellent points, but we have to bring those donors and those economic structures, the World Bank, the IMF, all of these disparate power holders and brokers, the ones that have the purse strings, they need to be educated in compassion. We need to have a foundational shift in those building blocks. And the only way to get a foundational shift is a revolution. We all know that. The only way for change is to revolt. And if it is a collective revolt, if it builds from the grassroots, then we stand a chance at real change and decolonizing, disrupting, and actually rebuilding with the power structures behind us. But now I'm starting to talk about socialism, and I'm starting to move into a whole different space. And I say this and with vim and such exuberance, because I really do believe that all the science tells us at this point in time that if we actually educate differently on the tenets of compassion, we can make positive change towards these ultimate goals. And socialism isn't a bad thing as far as I'm concerned. So I do believe that Dr. Tannous made excellent points, and you ask a very provocative question, but the power brokers need to be educated differently. The power, the politicos, the money brokers, the paternalistic top-down approach needs to be schooled differently, and it needs to come from a revolution of compassion.
Perhaps we can challenge the Carter Center to host a power brokers dialogue so that we can have this conversation. So Kelly, I'll leave you with that and shift to Gene and ask him to respond to that same question and tell us, if this system exists, how might we better serve them in the field when we prepare our global health practitioners?
I mean, I also agree. Most of these conversations and their logical conclusion is in global socialism. And so, if you talk to, say, Eyam Bibola, who's the chief editor of BMJ Global Health, he's talking about abolishing global health as, if we're seeing global health as just this, as another kind of apparatus for that revolving door I was talking about, then it's abolition as a mechanism to occult extractive forces would mean that we just throw all our weight into reparative justice. And so Michael Chung brought up some good points about this earlier, that if maybe the aim isn't to decolonize global health if it's just another apparatus with a different window dressing, but to really move towards the grassroots collective movement towards repair, reparative justice, reparations. And that's what my colleagues would say. We can't even get to have any of these kind of post-race or post-colonial discussions if legacies aren't repaired. So if we throw all our weight into the repair, into the reparative justice movements, then maybe we can actually have some dialogue on where to go, and maybe global health is left behind in that approach.
I absolutely, want to say this is incredibly exciting. My key takeaway is a fundamental question that perhaps our hosts can consider for the next event is whether we should continue with the construct of global health, or perhaps there should be a new paradigm of some sort named in some way that better prepares students rather than deliver, but to engage, reframe, rebuild in an inclusive manner, and serve the audience with whom they've been entrusted with their tools. And the last point I'll say is coming from Barbados and then going back to work across the world, a major point of conflict for me is the idea that in spite of all the money that has been spent and all the efforts that have been given and all of the visits, we persist, and COVID showed us health systems remain weak and underdeveloped, and communities are incapable of responding. Vaccine discovery happens outside of the low to middle income countries. Therefore, vaccine responses are limited in these communities. And I think there's a lot to be done. Compassion, yes. Equity, yes. Humanitarianism with power differential, power shifts are required. And Parmi, I am going to challenge you to continue this conversation, and so that we can begin to rethink what that new practice of health service might look like versus a global health pedagogical approach that exists in this colonial model today. Thank you for the opportunity to moderate. Thank you for the opportunity to engage with all of you. It has been a privilege. And Parmi, I'd invite you to take the mic again. Thanks.
Well, again, thank you all. On behalf of all the sponsors and who put this together, that was fabulous. I'm an optimist and a pragmatist, and I do think we have, thanks to you guys, we do have a path forward. This is not some esoteric thing that can't be done. It can be done, and I think with some action, we have our calling order, our call. So just in conclusion, we're going to be sending you all a post-event email with a survey, because we do want to hear your thoughts about how this event went, but also what would you like to see us do as an academic community moving forward. And then we will obviously have this website, we'll have this recording available on our website, so please to share that with your networks as well. So with that, thank you all, and and let's work on this together as a community. We have a lot of work to do. Thank you.
Thank you very much.